So I usually describe the brain as filled with spiders that make spider web. And the spider web is basically the scaffolding onto which the neurons crawl and make their connections. If the microglia see danger, two bad things happen.
Welcome back, every Bendy Body, to the Bendy Bodies Podcast with your host and founder, Dr. Linda Bluestein, the Hypermobility MD. As you may know, I have had aberrant mast cells my entire life, so I'm super excited to talk to Dr. Theoharides about mast cell activation and what we can do to help ourselves feel better. Dr. Theoharides is professor and vice chair of clinical immunology and director of the Institute for Neuroimmune Medicine in Clearwater, as well as the executive director of the Center for Excellence for Neuroinflammation Research at Nova Southeastern University in Florida. He's also the adjunct professor of immunology at the Tufts School of Medicine, where he was a professor and director of molecular immunopharmacology and drug discovery. He received multiple degrees from Yale, including his PhD and MD. He also received a certificate in global leadership from Tufts School of Law and Diplomacy and a fellowship at Harvard Kennedy School of Government. He has shown that the unique immune tissue cells and mast cells communicate with the brain microglia and are critical for neuroinflammation. Dr. Theoharides has over 500 publications and almost 50,000 citations, placing him in the world's top 0.05% of most cited authors and the worldwide expert on mast cells by Scholar, GPS, and ExpertScape. He was inducted into the Omega Alpha Omega National Medical Honor Society, the Rare Diseases Hall of Fame, and the World Academy of Sciences. He developed novel dietary supplements with unique combinations of flavonoids formulated in Mediterranean olive oil to increase absorption. He has received over 30 patents and trademarks. I am super excited about this conversation with Dr. Theoharides. He is an absolute wealth of information when it comes to mast cell and mast cell activation disorders. As always, this information is for educational purposes only and is not a substitute for personalized medical advice. Stick around until the very end so you don't miss any of our special hypermobility hacks. Here we go. I am so excited to be here today with Dr. Theoharides, and we are going to have some excellent conversation, and I hope your day's going well for you and that you're ready to dig into this.
Well, it's a real pleasure to be with you, and I'm looking forward to our discussion.
Terrific. So, can you just start out? I mean, a lot of the listeners of this podcast, of course, are familiar with mast cells and mast cell activation syndrome, but can you give us just a really brief description of mast cells and their role in the body and in health and disease?
Well, that's an hour in itself.
Exactly, it is.
All right. So mast cells are unique tissue immune cells. They come from the bone marrow, most of them. They show up in the bloodstream as precursor or progenitor cells, and then they go into tissues. And we used to think that each mast cell is the same, and definitely that is not the case. So depending what tissue they go into and what microenvironmental conditions they encounter, they develop into a different, what we call phenotype. So their ability to respond and their ability to potentially be inhibited, about which we might talk at the end, is very different. So we know for sure that they are present in tissues that are exposed to the outside world, such as eyes, nose, mouth, lungs, skin, gut. However, number one, a wonderful paper back about 5 years ago showed that the mast cells throw filopodia between the endothelial gaps that make up the wall of the blood vessel, and they sense what's happening inside the lumen of the blood vessels. So therefore, they can be sensitive to whatever is happening outside and inside the body. And point number two, they're present in the meninges that cover the brain, and in the central part of the brain, we call it the diencephalon, especially the hypothalamus regulates homeostasis, and the amygdala that regulate behavior. And in fact, the hypothalamus communicates with the pituitary that makes all the hormones with a small bridge they call them median emulans, or the stock, and the number of mast cells per unit volume in that little bridge is more than what we have on our skin. Yet the brain does not get allergic reactions. So that's kind of one point of the overview. The second point is that each cell contains about 1,000 small spheres. So I call the mast cell like a soccer ball filled with about 1,000 ping pong balls. Each one of those little ping pong balls contains as many as 100 different molecules. And when the mast cell is triggered, especially in anaphylaxis, all the small granules, secretory granules, little spheres, release their content. But over a period of 6 to 12 hours, the mast cell can make another so many molecules. And in fact, some colleagues wrote a paper about a year ago, Dr. Afrin and colleagues, and collected about 350 molecules that the mast cell can make. Now, the last point I want to make, to which we will, I'm sure, discuss much more in detail, is that histamine and the enzyme tryptase that have been typically associated with the mast cell is only the tip of the iceberg. Mm-hmm. Because in most cases where the mast cells are activated, they're not released. Let me stop there, and we might come back to what the mast cells might be doing other than bad things in the body.
So this is already fascinating. So when I think of phenotype, I usually think of clinical presentation and the differences in phenotypic presentations, or you might have a phenotypic presentation of, for example, hypermobile EDS that may or may not have a different genotype. So Absolutely. You're saying that we can also think of phenotype in terms of the mast cells themselves, and that not all mast cells are created equal, it sounds
Absolutely true. The mast cells obviously have in their nuclei information to make pretty much everything, like every cell in the body, except that as we mature as individuals, as species, as whatever, certain cells forget to do some things and do other things. And the reason I'm saying that is because the mast cells have existed for more than 300 million years, long before we had an endocrine, immune or nervous system. Mm-hmm. In fact, by virtue of the fact that they contain so many different molecules, other colleagues and I believe that they were kind of the multifunctional cell. It can release some hormones, it can release some neurotransmitters, it can release some immune material. At the time, as I said, that there were no such systems developed. So fish, for instance, octopi, lizards have mast cells that don't get allergic reactions. So we clearly believe, and there's evidence to that as we grew and developed through evolution, functions of the mast cell became somewhat not useful anymore. Give you an example. Let's say that we were walking in swamps and our feet were, walking in swamps. All kind of parasites are going to come up our body, whether it's through the skin or through the anal canal, etc. The mast cells have actually the ability to fight parasites and bacteria. In fact, they're triggered by such organisms. So millions of years ago, most likely those are the only defenses we have. Well, now we're pretty sterile in our environment. We get antibiotics, etc. We just don't use them anymore. To give you another example, we cannot actually heal wounds unless the mast cells are involved. When we tried, and we published this with colleagues from the Joslin Diabetes Center at Harvard, we created, if you allow me to say, diabetic wounds in diabetic mice. And we used either mast cell deficient mice or otherwise normal mice. The mast cell deficient mice took months to heal their wounds as compared to just days. So we do know that they have very useful functions within reason. My unfortunately late colleague, Dr. Markus Maurer from Charité in Berlin, who died recently while hiking in Italy, where he's been many times in the past, he was really a phenomenal guy, great researcher and lecturer. One of his first papers was to show that proteolytic enzymes released from the mast cells immediately degrade toxins. It can be toxins from snake, from spiders, whatever. But if it keeps on going, then it becomes a massive inflammatory problem. And unfortunately, we do not know how to regulate the mast cells. We don't know how our body regulates the mast cells. If we knew that, then clearly by the end of our conversation, we would have actually better ways to deal with conditions of mast cell activation.
And I think that's such an important point, that mast cells do things that are useful in the body, because I think so often people think, oh my gosh, I have mast cell activation syndrome, which of course we're going to get into what that actually is right now. But they think, oh my gosh, if only I could just get rid of my mast cells. But
that's not correct.
Yeah, right. They're essential. So can you explain then what mast cell activation syndrome is and how that differs from allergic or inflammatory conditions like eczema or asthma?
Sure. So, first of all, we should be thinking about mast cell disorders in general. And we separate those in three categories. One are the so-called primary mast cell disorders, such as systemic mastocytosis or cutaneous skin mastocytosis. Those, by definition, have more mast cells either in the skin or the bone marrow or some other organs like the liver or the bladder. Then we have the secondary mast cell disorders, which is the bread and butter of everyday sort of allergy. So you've got allergic conjunctivitis, sinusitis, atopic dermatitis, eczema, asthma, if you wish. And then we have the third category, the idiopathic. And as well know, when we don't understand something, we call it idiopathic. And there we have idiopathic anaphylaxis, we have idiopathic urticaria, we have idiopathic edema, and we have mast cell activation disorders, not yet syndrome. Now, mast cell activation occurs in all these conditions. Clearly, people with systemic mastocytosis have mast cells that are activated. If you've got eczema, you've got mast cells in the skin that are activated. If you've got asthma, you've got cells that are activated. So mast cell activation by itself applies to all these three different categories, except that under the idiopathic category, we have mast cell activation disorders or mast cell activation unspecified, where someone without having many mast cells and without any known trigger, such as an allergen, mast cells are activated. Now, why do we get stuck with mast cell activation syndrome? And this is where the major confusion is. Our colleagues have indicated that one should be able to measure high levels of the enzyme tryptase in the blood. That is true in 90% of systemic mastocytosis patients. It is true in probably less than 10% in cutaneous mastocytosis patients, which is kind of interesting. And we will talk about the mast cell activation. If tryptase, according to the criteria as they stand now, is elevated within 48 hours of an episode, and you have all the other telltale signs of, itchiness or, bloating or, whatever, then we call it mast cell activation syndrome. So you have to have, not that I necessarily agree, tryptase elevated within 48 hours of an episode. But there are three problems with that. Number one, many individuals don't have tryptase elevation. And in fact, Dr. Butterfield and colleagues from the Mayo Clinic have shown repeatedly that 24-hour urine levels of the metabolites of prostaglandin D2, prostaglandin F2 alpha, and leukotriene C4 are much more predictive than tryptase. They analyze patients that, according to them, they absolutely should be in the mast cell activation syndrome category, and yet 35% of them had absolutely no tryptase, even though they fit all the other criteria. And to make things worse, a paper was published about a year ago, and then our colleague Mariana Castells wrote a very nice editorial in the New England Journal of Medicine. So our colleagues had measured tryptase levels on 105 individuals, regardless of diagnosis. They found out the astonishing finding that about 30% of them had familial hypertryptisemia, and that's why tryptase was elevated. Another 30% had chronic kidney disease that blew everybody's mind, and the rest was actually malignant mastocytosis or aggressive mastocytosis. Hardly any mast cell activation syndrome was present. And yet we don't discuss this paper, which I find it very, very intriguing. And in addition, while we started saying that, for better or worse, blood levels or serum levels of tryptase, we used to say about 2 years ago, should be 11.5 nanograms per milliliter. As of a year ago, this was raised to 15 milligrams per milliliter because so many people just don't have the levels that they used to be. And finally, unless you have an indwelling catheter to draw blood within 48 hours and you go to some medical facility where they know what they're doing, no one can measure tryptase within that period of time. So identifying even those patients who would qualify as mast cell activation syndrome is exquisitely difficult. So much so that I had family recently from Tampa in Florida that had to go to the emergency room because the lady had an anaphylactic episode, and her husband, by the way, is a physician, and they mentioned to the emergency room personnel that she has a history of mast cell activation problems. And the answer, according to the husband from the personnel, was, "What's wrong with your breasts?" So this is emergency room in Tampa 2 months ago, where they had no idea what we were talking about.
Wow.
So the field is very confusing. And unfortunately, we make it more confusing because we use different terminologies. So mast cell disorders, mast cell activation disorders, mast cell activation, unspecified, etc. So as long as mast cell activation unspecified or mast cell activation disorders exist in the diagnostic codes, and it does, I will use those codes for a patient that doesn't have elevated tryptase, and I don't get necessarily stuck to call it mast cell activation syndrome if my colleagues insist that tryptase should be elevated there. And the approach to treatment is exactly the same.
Mm-hmm.
And what we expect basically will happen to these patients is exactly the same. So having the tryptase elevated doesn't make any difference in terms of treatment or longevity or other symptoms that one expect. But for some reason, most of our colleagues get stuck with MCAS rather than mast cell activation in general.
Yeah, no, that's very helpful. And I want to clarify when you said about 48 hours. So are you saying from the time that the blood is drawn from the patient until
From the
it's
episode,
actually...
let's say you have an episode right now that you feel like, it's coming.
Mm-hmm.
So from the beginning of the episode, you've got, according to the criteria, you've got 48 hours to have blood drawn and show the tryptase is elevated, because then presumably it goes down. But as we will discuss later, I hope, there are many, many, many triggers of the mast cells, which I will enumerate some, that we absolutely know do not lead to tryptase or even histamine release. We publish papers in Journal Clinical Immunology, Journal Immunology, Proceedings National Academy of Sciences, showing that triggers such as, for instance, viral proteins. We used coronavirus spike protein, and we actually published that it stimulates release of cytokines without anything else. We published that the first hormone released under stress, corticotropin releasing hormone, not only stimulates the mast cells to release only cytokines, but it resets the reactivity of the mast cells to other triggers. So, for instance, we've got now many patients with chronic COVID or long COVID that all of a sudden are allergic to everything, quote unquote allergic, because they can't use any other term. I suspect that, I'm giving a lecture to Canada in about a month, that multiple chemical sensitivity syndrome is actually mast cell activation disorder, but not necessarily with a tryptase tagged to it, because in such cases we don't see tryptase elevation. So I almost believe that we should change the name mast cell activation disorders to something else, but that's for another time.
I mentioned the other day when I was recording an episode just by myself, and I was musing on some different things, that I think it should be mast cell activation spectrum. Because
that would be wonderful.
Yeah, I feel like it's such a spectrum of just the diverse presentations and like you're saying with the labs. So you were commenting, of course, on tryptase and prostaglandin D2 and also leukotriene E4 in the urine. So in terms of the labs that you find most helpful and the diagnostic process that you do, can you share some of that detail with us? And if there's certain steps that need to be taken in order to make the labs show most meaningful results?
Of course. So I always say some labs are much more informative if someone doesn't have other comorbidities. But unfortunately, many of these patients have comorbidities. What I mean to say, we published, and so did Dr. Metcalf many years ago, and Dr. Escribano from Spain, totally independently, that at least in systemic mastocytosis, levels of interleukin 6 in the blood were more predictive of the severity of the disease, especially bone involvement, than tryptase or histamine. So this was published 15 years ago, 3 independent labs, different times. Now, granted, someone will say, well, interleukin 6, it's not a mast cell mediator specifically. Of course it's not. But if you don't have any other comorbidities and IL-6 is off the roof, then I've got to take it seriously.
Mm-hmm.
A paper was published about 2 years ago that in chronic spontaneous urticaria, vascular endothelial growth factor was very high, especially in those that were resistant to treatment. Well, VEGF comes from the mast cells. And we published, as I said earlier, that corticotropin-releasing hormone specifically induces release of VEGF. So what I usually do is measure total IgE, and I measure total subclasses of IgG, because IgG1 tends to be protective. IgG4 is involved in food intolerance, which is a little different, and we can talk about it, because many of the mast cell activation disorder patients do have food intolerance, which is not picked up by IgE. There's a caveat doing the food intolerance test, and I know many of my colleagues, allergists, don't really like to do it because if you eat something every day, it turns out to be false positive. So I usually tell families, patients, if you can live with a little boiled chicken and quinoa for 3 days, then do the test. Quinoa doesn't have gluten, for instance, in it. I've never seen anybody allergic to chicken, so you kind of go a little bit on the safe side. And then you can find out, if there are actually insensitivities or intolerances. In addition, before I go to the testing, we also have histamine intolerance, which is very different because histamine comes from the mast cells, but it's also present in many foods: avocado, tomatoes, peanuts, spices, cheese. And therefore, you can have a reaction to that histamine if you don't have the enzymes that break down histamine. And the main enzyme is diamine oxidase. And we can measure diamine oxidase gene polymorphisms in the United States. For some reason, we don't measure activity. In Europe, they measure activity as well. So if someone has polymorphisms and or low activity, then you can give supplements like diamine oxidase supplements. But there's a tricky part with these supplements because enzymes are broken down as many things by the acid in the stomach. So unless something is enteric-coated or acid-resistant formulation, it's all gone. And I get all kind of comments from patients that take diamine oxidase supplements and say they don't work. And then I ask them, what was it? Well, out of about 10 Dow formulations out there, only one is acid resistant. So you see how we misinform our patients not we, the companies out there misinform them, but we should be able to tell them also that enzymes will be broken down eventually. And enzymes, as we all know, don't get absorbed from the gut. Otherwise, we'll be giving insulin by mouth. Peptides are not absorbed. So the most benefit of the Dow enzyme supplements is what happens in your intestine, not in the rest of your body. So if the histamine is released in your intestine, then yes, Dow will work. And why is that important? Because histamine is broken down systemically within 1 minute and then ends up as methylhistamine in your urine. If, however, histamine is produced by mast cells in the intestine, it will be intact. And this is why if I suspect patients starting backwards, especially if they have GI problems, I ask for a stool analysis for total histamine which can be done in the States, and eosinophilic cationic protein, which comes from eosinophils but triggers the hell out of the mast cells, and calprotectin, which I think is one of the best indices of inflammation rather than CRP or erythrocyte sedimentation rate, etc. So I start with that. Now, in terms of blood, then I'll do total IG, subclasses of IgG, especially 1 and 4. Definitely, I'll send for a tryptase. Unless someone has chronic itching, I never ask for plasma histamine because it's really broken down very quickly. If, however, plasma histamine is elevated, that is important. And most of the time it's elevated, and we can pick it up by doing the so-called basophil activation test or Ig receptor activation test. And these patients have autoantibodies against the Ig receptor on mast cells and on the circulating basophils. And these antibodies, rather than blocking the reaction, they stimulate the basophils of the mast cells to release histamine. This is probably the only time that I see histamine elevated in the plasma, and when we do the basophil activation test, which both LabCorp and Quest do it, except that they're buried inside panels. So you have to ask for chronic urticaria panel to find it. You cannot just, unfortunately, ask for it, specifically. Okay. And then I do interleukin-6 and I do VEGF, because at least these are measurable. I would love to be able to do 2 more molecules. One is interleukin-31, because it is causing more itching than histamine and more itching than tryptase. And right now, there is actually a drug that blocks interleukin-31 receptors available in the state. So we have some more drugs, especially for the itching part, but not for the other symptoms. And then, to the extent that it is possible, I will ask for the metabolites that I mentioned earlier, F2 alpha for prostaglandin D2, and the leukotriene C4. Now, we are trying to create a panel that is much better than what we just discussed for mast cell activation. But the difficulty is, how do you validate it? Because we can validate it in systemic mastocytosis patients because I have access to these patients by other colleagues. But mast cell activation, as we just discussed, is a spectrum. So unless I have a very well-defined set of individuals, it's very difficult to validate a set of laboratory results. Anyhow, we're working on it, but and clearly, as we will discuss, individuals that might have both, POTS and EDS, etc., becomes even more complicated in terms of what do these comorbidities do to each other.
I have so many follow-up questions to that.
Please do. Keep on going. It's wonderful.
But I also know that we have so much more that I would like to cover than we're going to have time for. We're going to have to do a part 2 for sure. So let me start though with the DAO polymorphism, and if there's a specific lab that you order that through, and also the DAO supplement. You mentioned that there's one specific brand of supplement that is not digested by the acid in the stomach like the other ones are. So I'm sure people are wondering which one that is.
Okay, I've got to look it up now. But if
we can always put it in later in the in the
if
show
our
notes.
listeners actually search for acid resistant or enteric coated DAO, only one will come up.
Okay,
at least that I know as of about a month ago.
Okay,
but I'll find it. So I don't want us to break the sequence of thought here. Many of the laboratories that do genetic analysis these days will give you not only just DAO, they'll give you a whole bunch of things. So unfortunately, in the United States, you've got to do the whole list. And there are all kinds of such companies that do it. But they don't give you only the DAO. In Europe, I can ask for only DAO, and they'll give me only that. And that becomes obviously, much cheaper for the patients than doing the whole list.
I didn't know if, now you can send a regular lab order to LabCorp or Quest, and you can put on there, the MTHFR, polymorphism, and they'll just do it. You don't have to have special lab for that, like you used to have. So I didn't know if,
That's wonderful that they can do MTHFR, actually. They didn't used to. And in fact, they might have caught up. They might actually have, they might be using it now as well, for DAO, I mean. But there are things, for instance, there's GenoMind that does, such analysis. There's Intel XXDNA that does, but they will do all of them, though, not just one. There's Vibrant Wellness that will do, such analysis. There's something called Neoscreen. There's something called Tempus Genetic. There are many of them, and the prices vary, actually. Even 23andMe will do it, except that they don't tell you the results. So you need someone else, like a geneticist, to explain the results to you. Now, in terms of, there's another problem with the DAO supplements. As you will see, and I'm sure our listeners will see, they say units. And it's amazing because one supplement might say 1,000 units, and the other might say 30,000 units. Well, I mean, what are we talking about here? So they're not standardized at all. Obviously, the more units, the better it will be. And all of them, except for one, come actually from mammalian source, from pork. And many people, either because they're vegetarians or ethnic groups, don't want to do that. And there's only one company called Natur DAO, Natur, without the E at the end, DAO, Natur DAO, and that is actually from bean sprouts. But according to colleagues, it's not very active in spite of the fact that they list many units. So I would not necessarily, I don't want to discourage people from using them, but I just would like our listeners to do a little searching in terms of, what they find, how they use it. If it doesn't work, just switch basically the brand. And as I said, I'll try to create a little table and send it to you. If not today, maybe tomorrow, because I think it will be very useful.
That would be amazing. And definitely, I encourage people to look at the show notes because we'll put some information in there after the fact. So that's great. Thank you. Okay, so we're going to take a quick break. And when we come back, we are going to talk about the role of mast cells in the brain and neuroinflammation and how all of this actually fits together in the human body. So we'll be right back. This episode of the Bendy Bodies Podcast is brought to you by EDS Guardians, paying it forward in the Ehlers-Danlos syndromes community, patient to patient for the common good. I am proud to serve on the inaugural board of directors for EDS Guardians, a small charity with a big mission and a big heart. Now seeking donors, volunteers, and partners. Patient advocacy and support programs available now. Travel grants launching in 2025. Learn more, shop for a cause at their swag store, and join the revolution at edsguardians.org. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube, and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. Okay, I'm back with Dr. Theoharides, and we are covering some really great information about mast cells, mast cell activation, trying to understand the difference between mast cell activation, mast cell disorders, histamine, sensitivity, all of these different things that I think often tend to be lumped together. So I really appreciate you explaining all of that, kind of at the beginning. And when you talked about mast cells being in different parts of the brain, really what came to my mind right away when you were talking about the amygdala, that's the fear center of the brain, right? And we know that a lot of people with mast cell problems, with connective tissue disorders, anxiety is a common problem. And I have hypermobile EDS, by the way, and I have very active mast cells and anxiety. So I fit that description myself. So I would love to talk more about the role of the mast cell in the brain and also in neuroinflammation and how mast cells contribute to things like brain fog, migraine, and now we're going to go outside the brain, bladder pain, but also neurodivergence like autism. So,
oh, my goodness.
Yeah, I know. Big question. Sorry.
All right. No, it's okay. So in 1990, I wrote a review and I called the mast cells the immune gate to the brain.
Mm-hmm.
And the reason I did that, which holds, is outside the brain, as I said earlier, we have two endothelial cells that make the wall of the blood vessel. In the brain, we have another set of cells called pericytes, and they literally make up the blood-brain barrier, which is protective. What do you know? The mast cells literally hug this blood-brain barrier.
Mm.
So we've published electron microscope pictures showing that half of this blood-brain barrier is covered by one mast cell or another. Now, what is critical here is that the mast cell contains molecules that will open up the blood-brain barrier if it's released. So if you get, let's say, a severe mast cell activation instance, whatever the trigger might be, the mast cell will be activated around the blood-brain barrier and will make it leaky, just like leaky gut. It will be leaky brain, basically. So molecules will come now inside the brain, either because they were circulating in the blood, which they should be going into the brain, or for the mast cell itself. And the mediators of the mast cells are well known to trigger the brain defenders, the microglia. So I usually describe the brain as filled with spiders that make spider web. And the spider web is basically the scaffolding onto which the neurons crawl and make their connections. If the microglia see danger, two bad things happen. First, the good thing is they will try to attack the invader. That's fine. But they go overboard. So now they don't make scaffolding anymore. So we lose the connections, which I believe very strongly we've shown it as recently as this year to be true in autism. And they will also lead to autoinflammation in that localized area where the problem basically is. Now, molecules from the mast cell are not necessarily bad all the time. Histamine, for instance, which is found in mast cells, is also found in neurons. We call them histaminergic neurons. And histamine is very important for motivation, learning, and memory. So I always tell my colleagues and patients, if some antihistamine helps you, don't necessarily go overboard and take 300 milligrams a day, because eventually you will cloud your brain. And even the non-sedating antihistamines, once you start pushing the amount, will get into the brain. Mm-hmm. So the so-called second-generation antihistamines are good, let's say Zyrtec at 10 milligrams. Mm-hmm. We always say you can go 4 times the recommended dose. Mm-hmm. Once you start reaching that dose, your brain is affected. Mm-hmm. So we don't want necessarily to block the mast cells, as we said earlier, in the brain, or block all the histamine in the brain. So the mast cells are found also plentiful, not only around the hypothalamus and the amygdala, but also around the pineal gland that regulates our diurnal rhythm. Mm. So again, antihistamines can affect basically our sleep pattern, as well as a lot of histamine, and who knows what else might be released. Before I got involved in brain mast cells, other colleagues from Sweden had published that they saw collection of mast cells in the brains of individuals with multiple sclerosis, for instance. And that is critical because, as we know, much of the problem in multiple sclerosis is that immune cells that are circulating get through the blood-brain barrier in the brain. They recognize the myelin that covers the nerves as foreign. They attack it. Mm-hmm. And that's where I have basically disability that might be at various parts of the, it might be tongue, eyes, hands, etc. For many, many, many years, millions of dollars had been spent trying to convince everybody that beta amyloid plaques are the beginning and end in Alzheimer's. Mm-hmm. All of the studies have failed. And now our colleagues say that it's inflammation against the plaques, and some individuals have more inflammation than others, because 30% of the people that die of old age have plaques, but they don't have dementia necessarily.
Mm-hmm.
So this is why I worry about the mast cell activation, that it may be contributing to inflammation. And if people are super sensitive, such as mast cell activation disorder patients, they might be more likely to suffer of such neuroimmune conditions. We're finding now that individuals with long COVID not only have a lot of quote unquote allergic problems, as we discussed earlier, but they also have a lot of neurologic problems, such as brain fog that you mentioned earlier, etc. And colleagues have published in the past that systemic mastocytosis patients do have a lot of cognitive problems. They cannot concentrate, they cannot remember, etc. And even though earlier I said that mastocytosis is primarily a diagnosis of bone marrow mast cells, as you quite nicely asked earlier, how about the bladder, for instance, or the GI tract? We published almost 20 years ago that in this sterile condition called interstitial cystitis, it's basically sterile bladder inflammation, muscles are activated. In fact, one of the ways to address this condition is exactly what I say for everybody else. Avoid histamine-rich foods, for one thing, and then use some supplements to which we might get to later if we have time, such as Cystoprotect that we developed 20 years ago. And it's the only actually product, drug or otherwise, that has been helping these patients all along. So once the mast cells are activated, this is my worry, it's very difficult to turn them back. And since they release so many molecules, we cannot be coming up with antihistamine this or anti-leukotriene this or antiprostaglandin that or anti-VEGF, etc. So our effort has been for 40 years how to regulate the mast cells. I don't necessarily say to block the mast cells because, as we said earlier, we don't block them altogether. But fortunately and unfortunately, some of the newer drugs, especially for systemic mastocytosis, induce mast cell apoptosis. So they basically, the mast cells die. Now, clearly, if someone has horrible aggressive mastocytosis, that's the way to go. But I'm hearing, and I've been approached increasingly by patients that have mast cell activation syndrome, whether they do have it or not, it doesn't matter, that they would like to try these drugs. And I'm telling them they're injectable, they have horrible side effects, they're going to basically get rid of all your mast cells in the body. You don't necessarily need that. So what I see is a lot of behavior in individuals that have mast cell activation problems. And I don't say necessarily bad behavior, I just say behavior because they're different behaviors. I remember I used to travel around the world with a lady that had mild systemic mastocytosis, indolent systemic mastocytosis. And as you know, when you land in another country, and if you come into the US, you go through customs, but then you go through duty free. They force you to go through duty free. This lady would faint because of all the smells that she had to go through until we realized, and she wore a mask. I don't know why anybody would force people to go through jail, obviously to sell their products.
Yeah.
We don't think of what else we're doing to these patients. So here you go. The mast cell does not have receptors that we know of for odors. So what happens? So we did and published the following experiment. We put an indwelling catheter in individuals that were allergic to just one aeroallergen. And we measured cortisol, meaning activation of the hypothalamic pituitary adrenal axis, over time. And we just basically sprayed them with a trigger. They got cortisol, within 2 hours elevated. So before we got the paper published, the reviewers said, well, it's the stress because now their nose gets all stuffed up. So we said, good point. So we used as a control individuals that we just put a clothespin to their nose so they couldn't breathe. Cortisol was not elevated. So clearly mast cells in the nose triggered by the aeroallergen were releasing molecules that would travel up the olfactory nerve, stimulate the hypothalamus to release everything that stimulates the HPA axis. So you see how the mast cells can be involved in different ways. And very recently, I published an editorial, actually it was a letter to the editor, to Journalology Clinical Immunology, and I called it Skin Mast Cells Under Stress, because they communicate with sensory nerve endings. And a number of dermatology journals have published papers showing that, in fact, the mast cell can release molecules that sensitize the nerve endings. Then the nerve endings release substance P and CGRP, etc. The stimulate the mast cell, start having a reaction. So we have to block the mast cells.
Yeah, I mean that's just so fascinating, and I was going to ask next about triggers, and I often will tell people about stress. And you wrote an excellent paper, I believe it was called "The Impact of Psychologic Stress on Mast Cell Activation."
Correct.
I might get the title slightly
No,
wrong,
it was very close. Yes.
Yeah, it's fascinating because when I was a child, I mentioned that I have hyperactive mast cells. My parents used to think that my asthma was psychologic because if I would be at a friend's house and I would be laughing, or if I was under more emotional stress, I would have more asthma attacks. So my parents are lovely people, but I remember them
A lot
definitely
of
thinking,
physicians say, see, we used to call them psychosomatic diseases.
Right.
And then now we call them functional disorders,
Mhm.
because psychosomatic, doesn't sound very good. But we're still saying the same thing, except that we now know that CRH will do this. That there's
Mhm.
just no question about it. And since our publications, a lot of other colleagues have shown that CRH is released in the skin, and it's released in the bladder, and it's released in the gut. And it's pro-inflammatory rather than being anti-inflammatory. Now, in terms of regulation, just to make this topic even more interesting, as you know, mast cells accumulate around solid tumors, especially breast cancer. However, the cancer cells make the mast cell not degranulate, but release only angiogenic factors that make basically new vessels grow so that the tumor cell can feed itself and metastasize.
Mm.
If we could make the mast cell release, let's say, tumor necrosis factor or tryptase, we're going to kill the cancer cell. So the cancer cells are smarter than us. That's why I hate supplements that they say, let's say, flavonoids to boost the immune system. Well, I don't necessarily want to boost the immune system because it might cause more inflammation than not. I want to regulate the immune system. That's why we created some supplements such as Pure Loot or Neuroprotect that contain natural flavonoids, pharmaceutical grade purity, but they're mixed with olive oil to increase absorption from the gut, because otherwise we cannot get enough into our system. Maybe we'll have more time for this later.
Yeah, well, I definitely want to make sure that we have time to come back to that. So I'm going to link your website in the show notes, which is drtheoharides.com, but I'll put the link there so people can see it, because you have so much great information on your
Thank you.
website as well. And I know people are going to want to look at that. So
Sure.
a couple things I want people to go there specifically to look at. One is your extensive list of triggers and extensive list of things to avoid. But maybe if you can also tell us amongst those lists, if there's foods that are specifically more reactive in more people, and
Sure.
if you have any general guidance, because I think sometimes it can be really challenging. People can end up eating just a couple of foods, right? Which we don't want them to do that either.
And I'll tell you an example of something that happened just an hour ago, actually. So we should keep in mind that food, supplements, drugs, cosmetics contain numerous substances, and many of them are not necessarily disclosed. So starting with histamine, at least we know, as I said earlier, that tomato, avocado, cheese, peanuts, sardines, spices have a lot of histamine. And it so happens that many of these food substances have high salicylates. And to remind our audience, acetyl salicylate is aspirin. Okay, so Bayer added the acetyl group so it's not as corrosive to our stomach, and it became salicylate. But if you use herbs, a lot of herbs have salicylates. For instance, barks of various trees have a lot of salicylates, and foods like cumin, for instance, like curcumin, have a lot of salicylates. And the reason I'm saying that is we know the curcumin is anti-inflammatory, but it's anti-inflammatory if you really get it very pure. If you have a partially purified extract, there will be a lot of salicylate in it, and that might make things worse. Same thing with cumin. Cumin is a spice. Out there, you'll see on the internet that cumin is safe, but it has a lot of histamine. So it is safe if you're not histamine insensitive. So I was talking to a company, very well-known company that makes actually dietary supplements earlier, and I was saying how I'm going to extremes for the supplements I helped develop with this company Algonaut, ALGONOT, to avoid anything that I know is going to hurt them. So for instance, all the Algonaut supplements are tested for glyphosate. Glyphosate is a herbicide known as Roundup. It stimulates the hell out of the mast cells. And so does atrazine, which is another herbicide. Yet we're selling them like crazy, and no one is telling them that they're likely to trigger the mast cells. So I told them that I want supplements to be tested for X, Y, and Z, glyphosate being one of them. The other major problem we're having these days is what I'm sure you know, it's called alpha-gal syndrome. So alpha-gal is found in most mammals, not so much in humans, but not in chicken and not in fish. So, beef will have it, pork will have it. And what happens is you might be bitten by a tick. You might never get Lyme disease or other diseases like Bartonella, etc. But they will carry alpha-gal from whatever they had bitten before, squirrel, deer, cow, to you. Now you become allergic. And we don't test for alpha-gal. We can send to LabCorp request for alpha-gal, but the companies don't set for alpha-gal. So I had a case recently of someone who showed up with very red lips and swollen tongue, and they couldn't figure out. Sometimes we call it, allergic tongue syndrome or whatever. We always come up with, syndromes. Well, she was using chopstick that had actually, all the chopsticks have mammalian gelatin in it, and the gelatin had alpha-gal. She was sensitive to alpha-gal, and it was reacting locally on her face just by using chopstick. And the same thing could be with lipstick, it could be with mascara, it could be with whatever. And unfortunately, companies don't say that. They don't list, they don't test for alpha-gal, or they don't say it's gelatin, so you wouldn't know, unless it's like fish gelatin or something. So that's another set to worry about. Then we know that a lot of preservatives affect those that have mast cell activation. For instance, polyethylene glycol, or PEG, can trigger people. And unfortunately, some of the vaccines, including Pfizer vaccines, have PEG. So I usually tell people, just try some Miralax that we use for constipation. Miralax is PEG. So if PEG doesn't bother you, then you can try something that might have PEG. So you've got to help, our patients kind of find a way through, not necessarily just scare them, you can't use X, Y, and Z, they won't be able to eat anything. And then it is the red dyes, all kind of dyes. As you know, red 3 has been banned everywhere because it's carcinogenic. But red dyes trigger a lot of, allergic-like responses. And as I'm sure you know, one of the Benadryl preparations has red dye in it. So why would an anti-histamine, anti-allergic formulation have any dye in it? It's beyond me.
Right.
So I usually tell patients, families, try to get clear gel cups if you can. And many of these products now exist as clear gel cups, but it's hard to find them. Many pharmacies just don't carry them, so you kind of have to order it. And then finally, in terms of, foods in general, if you suspect, that's what I tell people, that something bothers you, then you have to pay attention to it. And the last point I wanted to make is what we call phenol intolerance. So there are many substances that are phenolic. Chocolate is phenolic. Strawberries, blueberries are phenolic. Pomegranate is phenolic. And many of the substances have more phenolic groups than others. So pycnogenol has 15 phenolic groups. Quercetin, or quercetin, however you pronounce it, has 5. The reason I'm saying that is those individuals are phenol intolerant, which again we can test by doing polymorphisms on the relevant enzymes, become very irritated. They cannot sleep at night. They get very anxious if they take too much polyphenolic content. For instance, the olive oil, which is wonderful, the more pure the olive oil, the more phenolic it is. And people do promote it as a polyphenolic anti-inflammatory olive oil. And we use olive oil in all the Algonaut preparations. But I don't want the polyphenolic oil because 30% of the people have phenol intolerance and they're not going to know it. And they might get, jittery. So you see how you really have to kind of go through all of this before starting saying, well, I really have a problem that needs medication. And then I usually go for some of the antihistamines, obviously, as long as they're tolerated, because many individuals cannot tolerate some antihistamines. 15% of the people get wired on the antihistamines, even though they're supposed to be primarily sedating. And at the same time, I will look for pure flavonoids, such as the ones made by alginate, especially liposomal, because that increases the absorption, and alginate uses olive oil for that. And please, I tell everybody, try to avoid the motto, if something doesn't get absorbed, I'll give you a lot more. So for instance, let's say I give you 2 grams a day, 2,000 milligrams a day of any combination of flavonoids. Only 200%, 200 milligrams, 10% will be absorbed. 1,800 milligrams will stay in your gut, shuts down your bioflora. So now you get SIBO. You start chasing your tail. Why do you have small intestinal, overgrowth? So too much of something is not necessarily good, as we spoke about histamine and antihistamines as well.
And I'm so glad that you mentioned about the gut microbiome, because that is something that I did want to ask you about specifically. I know the gut microbiome is so important, and if possible, we should be eating a diversity of foods and things. How does the gut microbiome interact with any of this? And also, what about probiotics or prebiotics? Is that something that's a good idea?
So there are mast cells in the gut, no question about it. If we have a parasite, we get allergic reaction, they're going to fire. We said earlier you can measure histamine in the stool, for instance, as an index if they're actually misbehaving. If they are misbehaving, they will actually affect the gut-blood barrier, as we said earlier, which will now allow more molecules to enter into the blood, and our immune system will be responding to those as well. So we need to shut down or calm the mast cells there. But the gut, as you well know, communicates with the brain, either through molecules that will go through the gut-blood barrier into the blood and then into the brain, or through the vagus nerves that sends all kind of branches down to the GI tract, stomach, etc., and they go, kind of back and forth. So we have to keep our gut as normal as possible, and we don't. Our diet in general is miserable in Western world. And many of the foods we do either trigger the mast cells or at least they don't quiet down the mast cells. So there are the so-called anti-inflammatory foods. These are foods that have basically flavonoids in them. But again, we have to remember that you cannot build up too much of those because you can affect everything else in the gut. There are the so-called good probiotics, as I call them. Those that contain bifidus. So the bifidus does help break down histamine. So I like the bifidus. And I watch out for the lactobacilli, especially in individuals who are allergic or sensitive to milk, because lactobacilli comes from milk, and these are not necessarily pure. So I've heard people using lactobacilli, primarily probiotics, and they're getting all kind of reactions, and then I chase it down, and they're sensitive to casein found in milk, etc. So I'm a proponent of using probiotics of any kind, as long as one is not sensitive to a particular kind or another. And the stress is a major, major, major factor, as you kindly indicated for yourself, because it will affect our absorption from the gut. It will affect how the gut works. It affects, as I said, mast cells talking in the skin and the brain. And I usually recommend, other than avoiding the stressors if possible, or doing some exercises like whether it's yoga or meditation or whatever, I usually recommend the herb ashwagandha, which is fairly safe. I recommend it in children as well, except that it is a little bitter. So unless you swallow a capsule, if you put it into some liquid, just taste it first, because it is a little bitter. So people don't. So that people would comply. And then, unless someone has either systemic mastocytosis or a history of anaphylaxis or asthma, in which case they might need an epinephrine pen, for a reaction, I like the drug propranolol. So propranolol, one of the trade names is Inderal, is a beta blocker. We use it a lot in people with hyperthyroidism. thyroidism because our pulse is very high to lower the pulse. But I like it because it works within 30 minutes. It's out of your body in about 3 hours. You don't get used to it and doesn't cloud your mental abilities. So I recommend it to students and performers and others. And you don't have to use it every day. You can start just before when you think that might be a very difficult day, for instance, and just take it for a couple of days and then you're off it. And now there are oximeters. It's very easy to titrate it because the oximeter gives you your pulse. So if let's say your pulse is 100, you've got to drop it down to at least 10 points lower. And if you take 10 milligrams for propranolol, doesn't do it, then jack it up to 20, and you'll see. If your pulse drops, you're at the right dose. You don't have to kind of bother your physician necessarily.
Okay. Well, I'm thinking. We've gotten through about half of what I wanted to talk about. So I think we're going to have to come back and do a part 2. But what I'm thinking is I'm going to have to start taking propranolol and ashwagandha before our next chat, and then I can fill you in on how that's going. Before we wrap up and get to the hypermobility hacks, can you tell me with the ashwagandha, who would be a good candidate for that? What kind of benefits would someone see? And if you're willing to share any additional details about
you
like
get
dosing.
mild relaxation quite easily, but it's not the kind of molecule that if you push it, you're going to get much more. So I usually, for an adult, it will be 500 milligrams twice a day and that's it. If it doesn't help them, it's not going to help them. For children, I usually go 100 to 200 milligrams a day, usually in some applesauce, some honey, something, so it's not, that bitter. But I've used it myself. So I know when I have some difficult days, I always carry a little propranolol in my pocket just in case. No, I do. Because, whether it's a patient or whether it's the university or whether it's life in general, we get hit every day with all kind of crazy stuff. We used to have much more time maybe for friends and others to vent. Now we don't. And sometimes we just have to deal with ourselves and it's not helpful. And the older you get, the more you worry, or at least I worry.
Yeah, me too. I could totally relate to that. So, okay. Well, I think that we should probably have a second conversation about treatment specifically and really get into, how people can really sort out what kind of foods might be causing them problems, because there's probably some people that are going to be saying, wait, what, olive oil? Sometimes it's good, sometimes it's not. Blueberries, that's something that's supposed to be really good for us, right? So I feel like there's some details in there that we need to come back and revisit, because you've given us such a wealth of information and so much that we need to digest. And I bet you there's going to be some questions from listeners.
We haven't spoken about EDS yet.
I know.
So we have to.
Yes. So I like to end every episode with a hypermobility hack. And you've already given us so many, of course. But if you have another hack that you can think of for people with hypermobility and any of these associated conditions that you would like to share before we wrap up, that would be great.
I would like to urge people with hypermobility, whether they have been EST or not, to basically do a very simple test, which is to say, scratch their arm, the underside of the arm, with a finger of the other hand or a dull object, one continuous line from the elbow towards the wrist, just like that. And then wait a couple of minutes and see if that will turn red.
Okay. Are we looking for dermatographism?
Yes. Because if they do, and many people do, that will be enough for me to start chasing mast cell activation after that. Because that means that only the pressure stimulated the mast cells. There's no allergen, there's no stress, there's no other trigger. And I would say 90% of the time I'm correct that there's something to be discovered. And no one has ever done that. As a study, how many people have dermatography, for instance, etc. And that might be also quite interesting. In fact, if you would like to do a poll with your patients, it will be almost publishable. Because from what I said earlier, there might be something lacking in the skin. We might find out that more individuals have dermatographism than the general population in general without having well-diagnosed mast cell activation disorder.
Mm-hmm.
I don't know whether you can do that. Usually, in order to publish something, as you know, you can't just send it open-ended. You've got to
Right.
send it, let's say, to 100 people, and if 60 people or more respond, then you've got some decent results. Otherwise, it might say only those that were interested, replied. But that's something you might want to consider, since you have so many listeners, and it would be quite helpful for all of us.
Oh, I think that's a great idea. And I'm looking at my arm, and it does
Is
look
it?
red.
It does. Ooh.
I don't know.
Okay.
You probably can't.
No, bring it a little. Oh, yes, it is. It is. It will disappear in about a minute or two. The longer
Okay.
it stays, the more reason to be chased.
And I do test people for dermatographism, or have been in their inpatient visits or in-person visits, not
I'm glad.
inpatient. But I usually do it a little bit differently than
How do you do
doing
it?
like well, I just would like make like a letter like that or something rather
No,
than.
you don't have to. So you can use you can use the back of a tuning fork. You can use the back of a hammer if you have those, for exam, or like a pen without the part of the pen that writes.
Uh-huh.
And I usually tell patients, don't do it if you've got long fingernails, because you might break your fingernails, and then I'll be hearing it forever.
Yeah, exactly.
But most of the time, just using your nail of a finger, it's good enough.
Mm-hmm. Okay. Well, so many great ideas that I would love for us to follow up on. And I'm just really grateful to you for being so generous with your time. And before we go, could you let people know where they can find you, where they can learn more about your work?
Okay, so you kindly indicated one website, which is Dr. Theoharides, Theoharides.com. There's another website which is much more involved. That's why I created the second one, which is called mastcellmaster.com, all one word, MAST, Mast Cell Master. And I would urge people, if they have the time, to watch on YouTube an episode from 12 years ago called My Mystery Symptoms and Mast Cells. It's easy to find. And there are two ladies. I happen to be lecturing in Denmark, and one patient that had been after me was in Copenhagen, and she had a television station. So we taped, or rather they taped us, her saying basically her case. And then a lady that I was traveling with, that I mentioned earlier, basically, that also had problems, and that I would interject and talk about mast cells and how they relate to some of the symptoms. It's quite informative, actually. And because there are also two patients talking about their issues, as we are discussing mast cells, it's easy to relate the mast cells to some of the symptoms they have. So, My Mystery Symptoms and Mast Cells. Okay. And now, I used to be at Tufts University, as you know, for 36 years. Now I'm down at Nova Southeastern University in Fort Lauderdale, Florida. And the reason I came down, two reasons. One is because they're very interested in integrative medicine. And my colleague Nancy Klimas has been at the forefront for Gulf War illness and chronic fatigue, myalgic encephalomyelitis, etc. So if you go Nova Center of Excellence for Neuroinflammation Research, you will see now a new site with a lot of information and a lot of what we're doing research-wise right now. So Nova Center of Excellence for Neuroinflammation Research.
Okay, great.
Okay.
Well, we're going to have lots of links in the show notes, and so much excellent information for people to really chew on before we do part 2. And go ahead.
And I should actually add, not so much for promoting anything, but at the website of algonot.com, ALGONOT, I do have actually scientific blogs, and those are much simpler than some of the sites that I have. So you'll see, for instance, a blog about bladder health. There's one. I don't have anything for EDS yet. I thought we will do it together, which is why I want to talk to you.
Yeah, I would love to do that.
So seriously, because very few people know about hypermobility in itself or EDS. or what we call now the triad.
Mm-hmm.
So it's, EDS and it's POTS, or dysautonomia and mast cell activation. And I think a lot of people should be aware of this because they do go together. And I'm working very hard with a colleague from New York. We basically searched a particular IBM database for health, and we have incredible results of how much more prevalent mast cell activation is in EDS. We will be publishing it either as a letter to the editor or editorial, but we really went over about 10 million cases. The difficulty, the difficulty in searching for the results is that these databases, many databases, using diagnostic codes. And years back, we didn't have diagnostic codes like mast cell activation or mast cell activation syndrome, etc. So it's hard to search for all the data. But we use different terms, different diagnostic codes, and at the end of the day, I can tell you, it was anywhere between 4 and 20 times more prevalent than the average population. But we're doing some fancy statistics right now to make sure that we're not missing anything. But hopefully we'll submit it within the month or so.
Wow. Adding to your incredible literary contributions.
I just like to read and write, Linda. That's all.
Which is wonderful because some of us are not as good about writing, that's for sure.
Well, you've got to balance everything.
Yep.
But I've come to realize, though, that many GPs don't read the scientific journals that we might publish, whether it's allergy, whether it's inflammation, etc. So, for instance, right now with two colleagues, I'm writing a different article about autism, but we will send it to Family Practice, the journal Family Practice. Again, I don't know how many GPs will be looking at that journal, but we've got to get the word out to the colleagues.
Yes.
2 years ago, I sponsored a conference here in Florida on interstitial cystitis.
Oh.
It was a day conference. There were 3 of the best people that know about interstitial cystitis that have not retired yet as speakers. I was the moderator. We send out emails and regular USP, United States Postal Service, invitations to every urologist in Florida. It was free. It was in Tampa, Florida, accessible. You didn't have to stay overnight. Only one urologist came out of about 500. Yeah? I mean, that tells you how desperate the patients are and how horrible we as physicians are.
Yeah.
We just don't want to learn, either because it's time consuming or because we're worried that we don't know enough.
Right.
But we should not be telling patients, as they had told you earlier on, oh, it's all in your mind type of thing. When you're complaining about stress and asthma, for instance. And stress worsens interstitial cystitis. We know that, etc. So if the colleagues are not willing to learn, I don't know how we will get to them. That's my worry.
Yeah.
And some of us, for better or worse, are dropping out. Let's say for mast cell disease, Dr. Butterfield in Mayo retired. Dr. Schwartz in Virginia retired. Dr. Metcalf at NIH retired. Mariana Castells either is leaving or just left Harvard. There's only one, Jamaki in Michigan, that's kind of left that really knows what they're talking about. And when some of these colleagues left and patients were shifted to younger allergists, I get all these emails saying, they tell me there's nothing wrong with me.
Right.
So all the work that had been done by our colleagues that retired is just not carried anymore by younger people. They should be even more open to these problems than we were when we were never taught any of this, back in our day. So.
Yeah, it's really crazy. And the whole, myth about tryptase elevations, and that's the only thing that matters, is so frustrating for patients because they're suffering. And so many times we can do things that are very, very low risk. And it's like, why not try?
Absolutely.
Yeah.
Look, I'm not against measuring it. And if it is high, then I'll pay attention to it because someone might need a bone marrow biopsy and other things.
Right, exactly.
But to say to someone there's nothing wrong with you because you don't have high tryptase when you have all the other symptoms, it's unethical, basically.
Yeah, it is. Yeah. And a lot of people have been traumatized by those kinds of appointments, and myself included. So
really?
It's so wonderful, the incredible work that you're doing. And we are, I know I can speak for all the listeners. We are so grateful for you and
thank you so much.
And are so grateful.
That's what keeps us going.
Absolutely.
So stay well. God bless
you.
You God bless all the patients, and hopefully we'll be back again.
Yes, I look forward to chatting with you again. Thank you so much for taking the time to talk to me today.
Thank you.
I have been wanting to talk to Dr. Theoharides for so long, so I'm so excited that this finally happened. And I hope you will stay tuned for part 2 of this conversation on mast cell activation and what you can do to help your mast cells be happier. Thank you for listening to this week's episode of the Bendy Bodies with the Hypermobility MD podcast. You can help us spread the word about joint hypermobility and related disorders by leaving a review and sharing the podcast. This helps raise awareness about these complex conditions. If you would like to dig deeper, you can meet with me one-on-one. Please check out the available options on the services page of my website at hypermobilitymd.com. You can find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, Twitter, or LinkedIn at hypermobilitymd. You can find Human Content, my producing team, at Human Content Pods on TikTok and Instagram. You can also find full video episodes up every week on YouTube at Bendy Bodies Podcast. To learn about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, and HIPAA release terms, or to reach out with any questions, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you so much for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.